Hello viewers, you're welcome to the African Media Hub, the home of Africa Alive, where we look critically at contemporary African issues as they affect Africans and Africans in diaspora. And today, we will be looking at a very serious issue that has been like a plague among African countries and even other African countries in diaspora. I'm talking about the impact of infertility as a social scourge for the Africans in diaspora. What are the medical remedies that the system can offer? And to discuss these issues with me today, we have on my very far right, Dr. Austin Oraka. Dr. Austin Oraka is a senior partner at a GP practice here in London, and is a specialist who has had over 18 years experience, post-qualification experience in medicine. He is also a specialist in the ear, nose, and throat. And you can believe that definitely for such a man of experience, he definitely would have something to say. And on my immediate right is Dr. Henry Okosun, who is a consultant gynecologist and obstetrician with the NHS. He also has his own outfit called the Regency International Clinic in London here. Dr. Okosun has over 20 years medical experience, and he is an avid contributor to medical journals and medical authorships all over the world. Dr. Okosun has worked in Nigeria, he has worked in Saudi Arabia, and right now he is seated right now in the United Kingdom, attending to the issues of gynecology and obstetrician as affects anyone, but particularly those of us who have that tropical background to our heritage. Ladies and gentlemen, please join me in welcoming Dr. Oraka and Dr. Okosun. You're very welcome.
Thank you very much.
We need to now look at the core issues that is there before us today. The impact of infertility as a social scourge. Let me start with Dr. Oraka. Dr. Oraka, what can infertility mean? Is it something that's just a case of a woman's problem, a man's problem? Can a man be infertile? Can a woman be infertile? What does it mean?
Well, thank you very much for that question. I think it's a very good one, as you've mentioned. In simple terms, infertility is the inability of a couple in a heterogeneous relationship to achieve pregnancy within a specified period of time when they've had adequate intercourse. Usually we say about 2 years, within 18 months. If they've been trying regularly, adequately, meeting each other adequately within that time, if they've not been able to certainly achieve pregnancy, then they can certainly be said to be assumed to be infertile. Okay,
so in that case, because we have some unspecified time gap, say 5 years, say 10 years, say 15 years, people can be termed infertile if, for example, a married couple, as often as the copulate, cannot achieve pregnancy. But we've had stories of people who are 40 years old in marriage, 50 years old in marriage, giving birth. I think one was just in the papers recently, of a 59-year-old woman who just gave birth. Dr. Kosu, what happened there?
How many years did you say?
The woman is 59 years old.
Okay, 59 years. Usually, if in those situations, there would have been some assistance from the medical field. Because once a woman is 50, the average age of menopause is 52 to 55 years of age. What menopause means in women is that they stop menstruating, they are no longer ovulating, and they cannot conceive naturally. So it therefore means that any pregnancy you find in that age group from about 50 and above, they are usually with assisted conception.
In that case, it brings me back to the issue. Is it a problem with a man, or is it a problem with a woman?
It can be a problem with either parties or both.
Okay.
So it could be, it's not solely one particular party, because again, ideally, if you look at it, fertility, or you say infertility, which is the opposite of fertility, for you to achieve fertility, you need both parties. Both parties need to be present, so you need the woman's egg, and you need the man's semen.
Okay.
To certainly come together.
Okay.
To certainly fertilize the woman's egg, and so therefore, when you say, then you have an embryo coming out of that, and then of course a fetus come out of that, and then they have a successful pregnancy, and of course a child, and then you say they're fertile because they're able to certainly achieve a pregnancy.
Okay.
Certainly, but if they can't achieve that within a particular time frame, is important when they find that, because we do see people who come to us much earlier, get couples who married, and they come and see us after 3 months of trying, when they can have a baby. Are they infertile or not? We have to be careful not to medicalize inability to get pregnant from infertility. So if you come and saw me 6 months, it may well be that you're not actually seeing each other adequately. The husband might be working somewhere else, only comes home once every month. And they've been trying for just 6 months without inadequate intercourse. So therefore, they're having difficulty getting pregnant. They may not be infertile.
Good.
I wouldn't want to medicalize that. So there's a good distinction between infertility and those who are just...
Okay. Dr. Okosun, how would you want us to look at it? I mean, a couple has been married for 2 years, 3 years, and they've had a very active sex life, and for some reason they're not pregnant. And yet, the warning is not to medicalize because of social factors like occupational interferences, which may take them away. But then, they may be coming together, say, at periods when they think the woman should be ovulating, and it's not working. And from your experience, when do you think a woman should, or a man, or a couple, basically, should start getting married? And then it brings me back to the question, really, who can be the party who is the victim, not at fault, but the victim now?
Okay, thank you very much. From what Austin, Dr. Oraka has said, you find that it could be either party or both. And if a couple is being together, having adequate sexual intercourse for 2 years, we tend to use 2 years, but it depends on the age of the woman. If the woman is less than 35 years, or let's say 32 years, we say 2 years. If a woman is about 35 years, we say 1 year, because we do know that women have what we call biological age. And once they've reached the time gap, we say, because if you tried for 2 years, 80% to 85% of women will get pregnant without any assistance, without seeing any doctor, without seeing anybody. So it therefore leaves us with only about 15% of cases to investigate.
Okay.
And during the investigation, another small percentage will get pregnant. So what are the investigations? So you have to look at the woman's side of it. Although in African culture, we tend to think it's always the woman that is at fault. Unfortunately, the statistic shows that it's 50-50. That means about 1/3% of cases are due to the woman factor. Another third is due to the man. And the two combined is the third case, the third, 1/3, yeah, so that's how it works. So we must realize that within our African culture or ethnic minority. When it comes to investigation, we say, okay, it takes two to tango, just as Dr. Austin has said. So we tend to start with, in most cases, because it's the woman that comes first. In some cases, they come with the man. Then you start the investigation. What happens is that the woman is supposed to ovulate every month. Sometimes they may skip some months. So you do some tests to say, is she producing eggs? And if it's producing egg and ovulate and they meet at the right time, the woman should get pregnant. If she's not producing, then there's a way we can treat it. Then 2, you look at are the tubes open? Are they patent? It's very important because fortunately, among the ethnic minority, or in literature say Afro-Caribbean groups, infertility due to the tubes being damaged is the commonest cause among our people. Okay. Because the majority of cases are due to infection. Then the next one is you look at other factors that can cause it, endometriosis, fibroids, but those just contribute a small minority.
Yeah, when you say infection, when you say infection there among the Afro-Caribbean people, infection of the tubes.
Yeah.
What does that mean? What infects them? Is it the food we eat? Is it the kind of medication we take? Is it that we have a knack of being very dirty, even up to the intestines or something? What does that mean?
When we talk of infection in men or women that has to relate to fertility or infertility, the majority of cases are due to sexually transmitted diseases, and the commonest one is chlamydia, especially in women. Fortunately, in this country, you can go anonymously to any of the sexually transmitted disease clinic to get treatment, and they can do contact tracing. But unfortunately, if you have people who are from ethnic minority, because of awareness or stigma, they may not take up those treatment, or they may not even go for contact tracing, or don't believe it has happened. So what happens is that if you have a sexually transmitted disease, and if it's not treated adequately, so it damages the tubes, because the tubes are very narrow, they are very small organs, narrow tube with what we call cilia. They are like hair within it. Once those hair are damaged, even when they are open, they cannot propel the sperm through the tube, or when the egg needs to be picked up at the right time, they cannot pick it up. Or even when they fertilize within the tube, they cannot move freely into the womb to be implanted, and that's why you can also have increased ectopic in such instances. Okay. So apart from chlamydia, gonorrhea, then if they've also had operations, if you have any operation within your abdomen, because the abdomen and the pelvis are within the same place, if you have operation of fibroid, appendix, that's why the tube being blocked in women is more common on the right, because that's where you have the appendix. If the appendix is inflamed, the tube is a very close organ. We also say that there are sympathetic effect. It's like anything in life. If you are close to each other, you are sympathetic to each other, they get affected, the tube is damaged. Okay. In terms of men, fortunately, men's investigation is very easy. It's far much easier. But fortunately, among the ethnic minority Afro-Caribbeans, men don't want to go for any investigation. It's either because they are scared. Although we say, okay, the social stigma is more in women, but you find that the men are more scared because they don't know what the outcome is going to be. So, so the men need to be investigated as well. I won't go for that.
Okay, then. Dr. Oraka, he has brought us into a realm of social scourge. If there is infertility pronounced against anybody at home, in Africa or in the Caribbeans or even in Asia, people have a different cultural tendency of managing it. But in diaspora, we are away from the nearest help, and we can't open up to one another. Like you said, maybe because of shame. I mean, so how serious is this? How serious is it for us to be in diaspora and say, for all the trappings of elitism and egalitarianism, which we have acquired from a Western culture, we still can't make children?
In my experience, it is serious in the sense that although the diasporans are abroad, they're kind of more isolated than if they were back home. Who do you speak to? Who do you share your problems with? So no one to talk to. So other than your doctor or friends, if you have friends. People are so busy, they have a silent mentality, everybody actually in a hurry to do their own things, and you hardly see each other. So it's difficult to know how to deal with that themselves. And often the time that can be in a relationship where they've been trying for quite some time and they just can't achieve a successful pregnancy, that can put strain. And the partners may not have who to talk to, who to confide in. If it's the lady, usually it's the lady, as Dr. Okosun said, who will normally seek help. And usually abroad, the first point of contact will be the GP that they will go to certainly discuss that problem. And infertility is a sensitive subject, it's an emotive subject that can be quite challenging both for the patient and the doctor, the clinician, who is managing them. And as clinicians, we try to manage them with due professional discretion that is certainly sensitive to each individual's needs. placed in the sociocultural context. So you might have different backgrounds. Infertility actually carries different scourge or stigma in different societies. And they come to you, might be the religion coming into it. Are they Christians? Are they Muslims? And in other ways, they have other wives in the family who have children. And they're the ones that can actually have children. Or as the partner has children elsewhere before with other relationship. And then they haven't had for this particular partner. So all these things come into it. The background, Africans, and even different Africans, again, from different parts of Africa, could be from Somalia, Nigeria, South Africa. They all have these perceptions, beliefs. It's a very strong thing again too, the belief, the culture, the tradition, where people feel there's been something going on in the background in the family. They can't explain it. There's something mysterious going on.
Yeah, in that case, Dr. Okosun, you are the man at the end of that ladder of consultation. You're the man who, for the NHS or your private practice, that's what you deal with every day, day in, day out. Now, when you meet this kind of situation and you look at it, that yes, these people need help, particularly among the people who come from these ethnic minority groups, what is usually the first thing you try to make them do? Thank God you're wearing two hats, in the NHS and in the private practice. Where do they come to mostly to get support, and how do they get it? And how, to what extent is the support much more of quality and durability? Is it with the NHS or in the private sector?
Okay. As you said, it's a social scourge, and that's affliction and all those ones. Because once a woman is infertile, in the past we used to say they are barren. You can't use those words these days. But you find that there's social isolation. They have no support, and they are marginalized, and they tend to be low-income groups. But it depends on the type of patients that come to us. But the first thing is that because you work as a team, you have a doctor, you have a nurse, you have social support, you have a psychologist. So we all work hand in hand, depending on the need of that individual. And again, you have two types of Afro-Caribbean in diaspora. You have those that are here legally. Those are probably easier to deal with. You have those that are here illegally, because the NHS, as you know, in the last few years, have now marginalized those who are illegal. That means you cannot get your treatment being paid for by the NHS. It therefore means their problems are going to be more. So, but if there are those that are here legally, the first thing is that they will see the GP, who would have taken what you call history, go through their story, then do the relevant investigations. We said earlier on, check, are they ovulating? Is the woman's tube is okay? Is the sperm okay? So if those three factors are fine and they can still get pregnant, then they will send to the specialist. Then you go through the whole system again. Then there are those, if you
when they send the specialist, who pays?
Yeah, if it's an NHS patient, it's paid by the NHS. But as you know, there are different borough or different council and what they can pay for. But we come to that when we come to high-tech treatment. But if it's simple treatment, because everything is fine, the sperm is fine, the tube is okay, or you say, okay, do ultrasound to see if you're ovulating, have timed intercourse. What timed intercourse mean is that, majority of people don't actually know that the certain time for women to get pregnant, because that's why if you are doing contraception, you can have what you call safe and unsafe period time. Unsafe time is when women can, so it's the opposite. So you can time them, they've ovulated, and you say, okay, this time of the month, or let's say you say your husband must be around in 1 or 2 days time, so that if you have intercourse, then the chance you get pregnant will be there. But unfortunately, that also put pressure on the man, because if you put pressure on the man to perform, they might not even be able to perform that same night. So that becomes a double-edged sword, a double problem. So that's that. Then, if you now found the tube is blocked, within the NHS system, they have to refer you for IVF. Then depending on the area where you live, what you call postcode, lottery, and your age. If you are about Before it used to be 37, but now they moved the goalpost to 40. Austin just told me, guys, and Tommy moved it to 35, which means if you are above 35, you will not be eligible. If you are less than 35, you'll be eligible. In some areas, if you are 40 and below, you are eligible for an IVF treatment. IVF means in vitro fertilization, that you are being helped, that they take the sperm and take the egg, put it on a petri dish and fertilize it before putting it back. So that's the... Then if the sperm, it depends on the level. There are simple tricks. If, let's say, the sperm is not too low, then you can talk to them about simple measures of what to do. It could be, say, okay, if you smoke, stop smoking. If you take recreational drugs, stop. We do know that obesity and all those affect, they can reduce their weight. And men, fortunately, the sperm is outside the body, and not the sperm, the testis is outside the body for a purpose. Because if the testis is within the body, the sperm cannot be produced.
Okay.
Yeah. So because it's outside the body, therefore means it needs a cool environment. Some people, unfortunately, wear very tight and rubbery pants, and that creates heat and kill the sperm. Sometimes you now say, okay, why not buy loose cotton type of pants or underwear? And it does help.
Okay. Let me just interject that. I don't want us to miss this point. This is very key. We are in diaspora. Once a person is above 35 years or 40 years, as the case may be, it cannot be eligible for IVF. We're in a sociologically advanced society where people like to understand their spouses. Some court for as long as 15 years before even talking about marriage. Some even live the first 50 years of their life saying they are partners before even saying they want to decide. Some even take as long as 15, 20 years of partnership or marriage to say, we want a child. There are various expectations there. So, how can we view the policy of the government in that regard? To say that at a particular age, if I get married at the age of 33, or 34, or 35, that's when I find the woman I love. And 2 years on, I am above 35, and because there's nothing else there, but we decided, 5 years after, that is when we plan to have children. And we cannot. I cannot be supported. How would you view that policy? What would your recommendations be to the government of the day?
What did you think, if I may come in here?
Yeah, please.
Now, before I say that, I think I just want to mention something important in support of what my colleague has said. Now, I think it's also the level of awareness from what you were saying. Those in diaspora, we're all in this rat race. People get consumed, we get carried away, and work, change your career and all that. Not mindful of the chemistry or physiology of the human being. Now, certainly women, for instance, women are born with a fixed number of eggs. Men are not. Men keep producing all through. So a woman, for instance, once they start to see their period, about say 12 or 11 years of age or 10, then from that day on is countdown. 1 egg less every time they see their period. Until the whole ovary becomes empty of eggs. And once the ovary is empty of eggs, then they go through the menopause. And then beyond that point, they can't get pregnant anymore. So if a woman starts a period, use a general rule of thumb, if they start a period very early, then say 8 or 9 years of age, then the likelihood is that they probably come menopause quite early.
Quite early, yeah.
If they start later, then later. Maybe in the family you can see that can be mirrored by their mothers and sisters. They can look at the mom. So, but like men, we produce all regularly. And for women too, the later they leave the pregnancy, when they're older, then there's that risk of likelihood of having abnormal babies, congenital deformity, Down syndrome, which is one of the commonest one. So people need to be aware of all this, when to start the family, when is the ideal time to do that. So therefore, if you're aware of all that, and again to infertility, the treatment and is expensive. In a system like NHS, for instance, where we have limited resources, that needs to be shared amongst the different branches of medicine. They've got to prioritize. You're going to look at acute medicine, things like heart attack, stroke, cancer, diabetes, and you've got to prioritize the fund that you have to treat all these different conditions. So if a lady actually comes in, unfortunately, it's not cheap, in my experience. So therefore, if you're going to prioritize funding, the government is constrained, and you can understand the dilemma and that challenge that they have for them. And again, too, with this social scourge thing again, it's also for us to Africans, it's also our own mentality and an attitude on having children. Some of us have had children, 2 children, some 3, but some still just want to have more. Some have been in a relationship before where they had 2 children, they're out of that relationship, in a new relationship, and they want to have a child for this new relationship. Even though that partner, the male, has a child elsewhere before. And sometimes the government can understand that. So the typical Caucasian society, if you've got 2 children, they're happy with that. And people can adopt, people can do all sorts of other things. But in our cultures, again, to that, again, is kind of alien to us. We actually find some people who genuinely cannot have baby because of their congenital abnormality. That's the way they're born. They just cannot, and they find it difficult to accept. Or to
Very, very significant, interesting that you mentioned about the timing and then the condition of the babies they have. But I want to look at the issue of funding, which you also brought into it. If it's going to cost NHS so much money, and that is a factor for which the NHS is considering, amongst other factors, like distributing resources between the other prevailing medical sectors, then I want to ask, why isn't Dr. Okosun's private medical practice more viable than the NHS? Why isn't it more viable? Why isn't it more appealing? Why should we then say that, for want of a better word to use, to say that NHS is getting saturated and therefore we can turn over to private practice and find the viability? Doctor, you want to say something about that?
Okay, I first come to what I've mentioned earlier, and Austin also talked about, is the biological age. We do know the statistics is shown clearly. If a woman who is between 19 and 26 years of age, their pregnancy rate every month is 50%. That means if they have a regular partner, the chance they will get pregnant is very high. But unfortunately, during that age time, they don't really want to have children. They might result in having an abortion that will lead to infection and damaged tube. Then when a woman is 25 to 28, their chance of getting pregnant goes to 30%. That means if you have 10 women, so 30% of that, 3 out of 10 will get pregnant every month. Do you understand? So once the woman hit the age of 37, 35, 37, it comes to 20%. At the age of 38 and above, it comes to 10%. And that was the rationale why the NHS uses, there's what we call cost effectiveness. So if you're going to spend, let's say, £5,000 for one treatment, and the chance of the woman getting pregnant out of 10, 1 out of 10, so can you justify it? I don't know if you understand.
Yeah,
so,
I do understand.
So
yeah.
these are the
So you want to
that's why
spend the money on somebody who's got 3 out of 10.
Yeah, who has a higher
10.
chance, yeah.
You know.
And also within the NHS, they also, if you had one child, either partner, you are not eligible. And you're only entitled to 1 IVF treatment. But some council might be about 2. Do you understand? They're just trying to spread it. And if you look at the literature, I'm not talking of just peculiar to us, the literature all over the world don't believe the ethnic minority need to have more children. They actually think you need to curtail it. I don't know if you read that. So they don't think it's a problem. But we know because of our culture that you need to have more children. Then when it comes to, okay, should the private clinic like ours, Regency International Clinic, will be more viable. But unfortunately, because it's very expensive, they cannot afford it. Because you find the average cost for an IVF is about £5,000. And if the average income for a couple, even combined, might just be about £40,000.
Per annum?
Yeah, per annum. So if you divide that over 12 months. So you find that most of them, they may have to save over 2-3 years before they can afford it. So these are the things you look into. But you find that people who actually take up the IVF treatment within the private sector tend to be those who are in the middle or upper class and tend to be white, or if they are Afro-Caribbean, those are also in the upper class. Okay. So these are the problems.
But without saying that, I mean, without trying to say that the typical ethnic minority couple is having the noose around their neck because of the funding position. What is it that private people like you will give them hope and succor and make the races come true? What do you do to help the finances? Because if they can't do it, then there is an issue.
If I may just comment very quickly. Now, I was going to respond to that because one thing is level of awareness. Now, in the UK, for instance, of course, the health system, and everywhere you've got the national health system, you also have the private system. And like Dr. Okosun mentioned, the class social class is actually affected. It's actually the lower social class. And so therefore, how resourced are they to build out? Because you've got the option to either go to a GP or go to a private treatment. So they're free to the first point of all will be the GP. Because they know it's free. They can be seen by the GP, they can be referred on to a specialist. And there's that waiting time game. When they get to their oldest who say, well, look, I can have this, it's an insurance, I can have an insurance policy out there. They can go and have a health insurance cover. If you have a insurance cover, which tends to be for those who are in the working class and all that, they can afford that, then they can really look at private. In which case, if you haven't got an insurance cover, then you're going to be paying out of your pocket, in which case it becomes more expensive. So therefore, the thing here is that in terms of the private unit trying to encourage those, one is raising the awareness that we're there. Because with infertility, it actually takes investigation, education, raising of awareness, and most of the tests that they do, the screening tests we do are things like the chlamydia infection, which is the commonest cause of infection, is now really freely available out there. GP, pharmacists even do it. Even some, you have some drop-in centers, sexual health clinic do it and all that. So you've got all these kits now that have now been made in such a way that is now kind of freely available to those people who are aware of the symptoms. And in terms of actually moving on further, refer to a specialist, that's where things become more expensive. And in that case, either you're going to be a self-funding patient or have an insurance policy which can enable you to actually go privately. So the private wing is there. Now, the NHS is actually working closely with private. Now, where they're referring patients to private hospitals because of the backlog of work. Okay.
So let me just quickly take on this because our time is fast spent and the audience would like to have a feel of you as well. The insurance, having an insurance policy is key to supporting medical services in that regard. So it is readily advisable that people should have that insurance policy to be able to get a service. Now, when we're looking at medical remedies, if we can just quickly take on that, what do we consider medical remedies? Is it that which is orthodox, like the NHS or that Regency National offers? Or is it medical as well, to look at the Chinese traditional medicine or even the African traditional medicine? Is that also medical? Because when we say medical remedy, if those are medical as well, then why can't they also be admitted under the NHS scheme?
If I may comment there again, then of course we're now coming from the specialist side.
Okay.
Now, because this is the bread and butter stuff of infertility, people come to you, they say, well, we can have a child. And you're going to look at them. You can tell that they're a young couple or not. And then you want to find out how long has it been going on for. And if it's not been going on for more than the required period of time, that's in 2 years, 18 months, 2 years. And you want to say, are they adequately seeing each other? So many times a week are you seeing each other? And then are they living together? What kind of work are they doing? The spouses, hard work, are they living away? One comes home every 3 or 6 months. So for things as simple as that, you can actually educate the patient and say, well, look, this is when you need to meet. As I mentioned before, you need to know a woman actually ovulates at a particular time of the month. And can you identify that? And there are kits available that you can buy over the pharmacy to identify when you ovulate. And there are things you can do to find out when you ovulate. And once you can do that, then you are encouraged to meet around that time to improve the chances. So these are natural, simple remedies that you can carry out. And then people might be under lots of stress for one thing or the other. And you can manage that stress, relaxation therapy, simple things like that.
Okay. In other words, awareness can help us limit that borderline that we want to cross. So,
yes.
Doctor,
okay. The other remedy you talked about, the there's what we call the orthodox medicine, which we practice, because these are being validated, because you want statistics, you want validation, it's been tested. But when you talk of Chinese medicine, or we call it complementary medicine, many of them are not validated. They've not been subjected to
or even the African one. Basically.
Yeah, I didn't want to come to African one. Yeah,
we should.
Because the African one, some do actually do more harm than good. But I won't go into that because I remember when we were training in Nigeria, you find some people to induce abortion or to get pregnant, they put some herbal medicine inside the vagina. What happens? Because some of these things are caustic. It burns the whole vagina, the whole thing is close together. What they want to achieve is no longer there. They cannot even have intercourse. So that's why I said some of these things are not validated. But at least the orthodox medicine, we know it works. You can say, okay, if the tube is blocked, we can unblock it like we do that in Regency International Clinic, depending on the cause and the extent of damage, which is being validated by American literature. If the mass sperm is medium, I mean it's not too low, it's not normal, then you can do what you call intrauterine insemination. You watch the sperm. At the time the woman is ovulating, you put it within the womb, and you're hoping that you shorten the distance for those sperm to travel. And you find that pregnancy rate is about 10 to 15%. Then if it is IVF, which is the ultimate, where you actually take the sperm and the egg together, fertilize it, put it back. These are all validated, and the pregnancy rate is about 30%. If the woman is more than 40 years, as we talked earlier, you have to get egg from a younger person, because we know the eggs that are remaining, as Austin has told you, they are no longer of good quality. Even if they fertilize, they are more likely not to, even you put it back, are not likely to implant and result in successful pregnancy. So if you get from a younger person, you find that the woman, the chance of her getting pregnant is almost as if of a 20-year-old. So that's why you prime them. I'm sure some of you heard of a 60-year-old. You mentioned 59. Yeah. There have been who are 65 years old. Although those are ethical issues, we are not going into all that.
Ethics of medical ethics.
Yeah. So you find that the orthodox medicine is being validated. The rest, we cannot speak for them. They have to justify whether it works or not.
Thank you very much for coming.
Thank you.